Thanks and welcome back to State of Morris County 2012. We're here for our final discussion this morning on healthcare, the state of health in Morris County. And I ask each panelist to introduce themselves. Bob, why don't we start with you?
Yeah, my name is Bob Schermer. I'm the manager of the Morris Regional Public Health Partnership. It's an not-for-profit organization that coordinates many of the activities of the 39 health departments in the county.
Eva?
I'm Eva Turbiner. I'm the President and Chief Executive Officer of Zufall Health Center, which is one of 20 federally qualified health centers in the state of New Jersey.
And Mike?
And I'm Michael Avaltroni. I am the Interim Dean of the Fairleigh Dickinson University School of Pharmacy. We are actually only the second school of pharmacy within the state of New Jersey and the first affiliated with a private institution. So happy to be here.
Nice to have you here, and thank you again for hosting. Fairleigh Dickinson is a fabulous place to have this event. So let's start by talking a little bit about Morris County and the state of health generally. You all are in a pretty fortunate position, and you are the second healthiest county in the state of New Jersey. I think that's pretty consistent. So I guess, Bob, that means you're doing something right. Your group you want to take the credit for that?
I'll pass it along to the health officers, the physicians, the hospitals, the federally qualified health centers, and the nurses in the county. But we've had a hand in it. Morris County, as you know, has 492,000 people, 39 municipalities, and we have recently, not so recently really, but within the last 5 years, we published a county health plan that identified many of its needs. It's a mixed bag. We have no single priority except perhaps access to care. New Jersey is excellent in its health in a number of ways, but it is also a county that has the highest rate of female breast cancer among the 21 counties in the state. So there is improvement to be made.
Are there some other areas of concern that you would look at specifically, either by municipality or by region in Morris County?
Yes, the national recession has affected New Jersey. That in turn is a result of declining tax revenues to municipalities, which of course affects the municipal budgets, and public health is something that is municipally sponsored. In 5 or 6 years ago, we had 15 or 16 health officers, several of which of course took care of several towns. Now we have 12. The significance of that is, for example, several years ago when we had the threat of the pandemic, the health officers got together. They're a very able bunch, and in a matter of several weeks they delivered 50,000 vaccinations for that pandemic to the population very quietly, very efficiently, and in a highly professional manner, organizing themselves, public health nurses and health educators, to get the job done. The reason I mention it is that since we have a decline in the number of health officers as a result of municipal budget cutbacks, I don't think we have that strength anymore. I think we're witnessing a deterioration of public health for financial reasons. That's the weak spot that I see.
And that's one of the questions we've asked in every county is there a safety net, and how effective is the safety net, even in a county like Morris County? Eva, you are the safety net, essentially.
Well, we're part of the safety net. Zufall Health Center serves, last year in 2011, we served 15,000 low-income residents, predominantly of Morris County. This year we're on track to probably up that to 17,000 patients, close to 50,000 visits. So we're seeing a lot of people who have few other alternatives. And so we believe that we're providing primary and preventive care to keep people healthy, to keep them out of the hospitals and out of more acute care settings. I think in a county such as Morris County, one of the issues is access to specialty care, diagnostics, medications. All of that is really where I see a lack of safety net. And although the county-wide, the statistics look very good, we know that in subpopulation groups, the statistics look far worse, and that's the group that we're focused on. We also know, and I think it's important to note, that what goes on in the hospital, in the doctor's office, is a very small part of health, that there are social determinants that really make a difference. So what are we all doing right? Well, at the margins, we're doing some good things, but what is mostly contributing to the health of Morris County is the fact that it's a relatively wealthy county with people who have insurance.
Mm-hmm. And I think we want to talk a bit later about the lack of specialty care that you talked about, the lack of coverage, the access issues. But Mike, let me ask you before we move into that, tell us a little bit about the School of Pharmacy and what you're doing, because it's a relatively new program.
Yes, we actually just seated our first class in this past August, incoming class of 81 students, and we're focused primarily on being a slightly different focused pharmacy school. We're looking really at a focus on public health. We're focused on some of the opportunities that pharmacists have going forward, and some of the things that we're excited about really building in a future healthcare professional. Things like basic communication skills, leadership skills, and fundamental skills really to interact with patients at the primary care setting. What we realized very quickly when we were exploring the plausibility of a pharmacy school was that pharmacists are going to need to be one of many people on the healthcare team who are going to fill the role of that's going to be vacated by a shortage of primary care physicians. We realized very early on that everyone we spoke to, every stakeholder, started to articulate the fact that there's really going to be a large gap in that sort of fundamental first-line primary care.
And you don't see that changing in the future?
I don't. I think the projection is tens of thousands of primary care physicians are going to be sort of the shortage that's projected nationwide, and I see it being significant here. What you're finding is that due to a lot of circumstances, most physicians are going and specializing. And what you're finding then is that that basic level of preventative and first-line care is difficult to find. And you probably see that as much in Morris County as you would in any other county in the state or any other area in the nation, where it's difficult when you look up in the yellow pages to find out just a general internist. Mm-hmm. There's not an abundance. And as a result, what we're finding is that pharmacists need to be poised to take on the role of a primary care provider, more than just a dispenser of medication, to be a medication expert, to be someone who is trained and educated to immunize, which is something that New Jersey has sort of led the way in immunization training for pharmacists. Someone who counsels patients and manages their medication, particularly in an aging population. That's going to be a huge part of the pharmacist's day-to-day role. The statistics are that people over the age of 75, I believe, are on an average of between 15 and 20 individual medications. What you find is that when you start to, as a pharmacist, look a little closer, many of those medications are either doing the same thing or are working at cross purposes. A really strong pharmacist with patient skills and also that knowledge base is poised to be the person that intervenes and does what they do best, which is to know the medications, to know the patient, and to know the best course of care. And
that's a great segue into starting to talk about the Affordable Care Act, which is, as we know, hopefully changing healthcare and access to healthcare for everyone in the country. The patient-centered medical home is supposed to provide a system where everybody, where the primary caregiver is really kind of not a gatekeeper. We're getting away from that to a caregiver and a guardian, if you will, a healthcare guardian, where a pharmacist would be an integral part of that system. The irony, of course, being that I always look at PCMH as kind of what doctors are supposed to have been doing all the time anyway, but now we're really, it's a formalized system of really paying attention to the total patient, so that you don't have those gaps in care or the overlapping medicines or things like that. Do you see that the ACA is making a difference already?
Well, it certainly is. We are in process of becoming a patient-centered medical home. We also agree that as a federally qualified health center, it's the model that we've been trying to attain for years. It is the primary care provider as the care manager. It is, however, a very labor-intensive and costly model. We believe that the costs to the system, eventually the patient-centered medical home will save the entire system a lot of money, but how does the primary care provider get compensated for that? Certainly under insurance schemes there is some bonus for patient-centered medical home. We have a full-time clinical pharmacist on our staff, and she does exactly what was described, and she is integral. but nobody pays for that.
Right.
And how do we afford that? We do it with grants, but that's not a sustainable system nationwide or
and that
statewide.
cost savings may be long-term rather than short-term.
That's correct. Long-term, or the cost savings are for hospital care that doesn't need to be rendered, or surgeries that don't have to happen, or decreases in emergency care. How does that money get to the primary doctor? And that's why so few doctors are becoming primary care doctors. The money is an issue.
Bob, do you see the Affordable Care Act as having an impact on quality or the efficiency in public health?
Yes, and a very positive one. There are 9 titles to the Affordable Care Act, and title number 4 is almost perfectly designed for public health. It's for prevention. In our country, the history has been that we treat the acute care emerging symptom. That's why we have such wonderful hospitals that we do. We want strong hospitals, we want strong physicians, but we need a strong system of preventive care. For the first time on a national level, the Affordable Care Act is going to stimulate prevention with a variety of measures and sophisticated services, including the medical home, including a variety of services for a variety of needy situations. And I'm looking forward to it as a public health professional so we can do our share.
Let me just mention the other, I think, big piece of the Affordable Care Act that's already out there in the community that many folks may not be aware of is the support for adoption of electronic health records. This is a
huge
big
push
piece.
in New Jersey
and
for this.
The Affordable Care Act made available $25,000 a physician, not just for not-for-profits, not just for hospitals, but for private physicians as well, to adopt meaningful use of electronic health records. That is having a big shift certainly in Morris County.
Interestingly, because in some places where we've talked about the adoption of EHR, and the consensus has been that while you may see some long-term quality improvements, you're not really going to see a cost savings.
That's correct,
to
and
EHR.
that's why the Affordable Care Act provides funding to help support the adoption, because it isn't cost savings. In fact, what you find is you're seeing what you haven't done. When you look at that electronic health record, suddenly all of the tests that haven't happened and preventive services that haven't been given are very obvious, and it is then incumbent upon you to make sure that those pieces of care are given on the primary care provider or whoever is using the electronic health record. No, not the patient, but the provider, to make sure that the patient gets those services.
Yeah, I'm going to want to get our pharmacist friend commenting on this one, but I read an article in a rather authoritative source, the AARP publications, where they cited a woman who had gone to 58 physicians to get her prescription filled for a particular type of drug that she was after. Nobody detected this until months later. Now, there's a perfect case for the electronic health record. If you had her particular history on a card and was able to coordinate that through a reasonable database, the same type they used to tell me that I got a ticket once in Georgia from the police department, I think we're going to be well ahead of the game. How do you feel about that?
I think one of the things that we hear anecdotally all the time, having worked with a lot of stakeholders in community pharmacy as well as hospital pharmacy, you're finding that even in a sort of a more practical day-to-day, you're seeing that a person who is elderly or who is unhealthy for any reason is oftentimes confused by the fact that they're going to see 5 or 6 different specialists for a random number of different conditions. And they're being prescribed things, most of them having a very obscure name, but also oftentimes a generic. There are many anecdotes where literally the person will come into the pharmacy with a Ziploc bag and say, this is what I'm on, and dump it on the counter. And the pharmacist will find that they're on the same thing 3 times. One of them under a generic, one of them dispensed as written with an actual brand name, and one of them doing the same thing but a slight variation.
And I guess we can assume that these people are using different pharmacies, and that's how they're...
And exactly, or oftentimes they're getting trials or a small sample pack from a physician's office, or so you're seeing a lot of different means to dispense. And of course, the patient is presenting side effects, and as a result, you're finding that the side effects are the result of having 3 times the normal dose, or finding that 2 things are completely working cross purposes. But again, unless, as you said, unless you have all things coming into one clearinghouse at one pharmacy, which you would then see a very effective contraindication pop up on a screen, so you'd know you wouldn't prescribe or you wouldn't dispense what was prescribed. But oftentimes, if you're going to 2 or 3 different pharmacies, or you're doing mail order for some and you're picking other things up, and as I said, sometimes you're getting a 7-day trial of something at a physician's office. It's just, I think what you're finding is that maintaining your own personal health under many different umbrellas at many different times is a challenge for people who are very healthy and are very aware. When you find that people are struggling with their medical condition, it becomes that much more cumbersome, that much more difficult to do.
Well, you mentioned that it's incumbent upon most of the provider to coordinate all of this, and clearly pharmacists are stepping up to the challenge. But what about patient responsibility, and what about health literacy, educating patients to take some responsibility for their own health?
Absolutely. I think the patient has to become a partner in the care of their own self. But many of the patients are not health literate, and they are afraid to ask or challenge or question their provider about the medication. We actually received funding for a 3-year project from the Robert Wood Johnson Foundation to promote health literacy in our community, and we've partnered with community agencies. Folks are not just health illiterate, but oftentimes, certainly among the low-income patients, they are illiterate in any language. And so how do they read instructions on a medication bottle? How do they really understand what the nature of the tests that the doctor is sending them for? We teach our patients to question. We have the talkback model and Ask Me 3, and we teach our patients, yes, it's okay to question what's going on. And then we also provide them with a care manager who they may feel more comfortable in questioning those issues.
You mentioned the language barrier. What are some of the other barriers that are in place?
Well, Morris County in particular is transportation. For low-income folks, there is no transportation. And you know, that we face that constantly. Patients are forced to take taxi cabs. The buses, while there are some buses and there is a train system, those are geared more towards commuters. And it's very tough if you've got to take 3 kids to a doctor on a bus, and then the next bus isn't for 2 hours. It's a whole day of torture.
Much of Morris County is rural.
And much of Morris County is certainly semi-rural. There's a question of any part of New Jersey is rural. But yes, those are
may not be served by any
real
bus or train or anything.
Right.
It requires transportation of your own to get there.
Absolutely. And so transportation, language barriers, of course, money. You know, the lack of insurance is overwhelming to people. They have not the ability to be served by the provider of their choice or to get in anywhere. And Morris County, and this is specific, does not have major teaching institutions, so that the specialty clinics where the folks in the larger cities are sending uninsured patients aren't here. And that is a real absence in Morris County.
You
it's
have
a real
hospitals,
issue.
obviously.
We have hospitals, but the hospitals don't employ their physicians. And so therefore, if you're an orthopedic surgeon, you do your service to the community by covering the ER. So if somebody comes in with a broken arm, you get called out of bed in the middle of the night. But that doesn't mean in your private practice you have to see someone who may have a less emergency situation.
But still require that care.
But still require the care.
Bob, as a public health coordinator of all of these public health officials, how do you deal with some of these challenges to promote the general health of the county?
Well, picking up on what Eva said, we're very much in favor of increased health education. And it's not just a language problem, there's cultural differences. So for example, there's a tremendous amount of people employed in health institutions in Morris County, and I'm an advocate of more. We live in a service economy. Here's a service that's worth expanding. So for example, down in Vineland in Cumberland County, they are employing a health worker called the community health worker. This person doesn't have to be a PhD, they can just be a high school graduate or less, but they have to be culturally competent with the group you're after. So you might say, we're going to find somebody who understands the folks who are living in Dover, the folks who are living in Boonton, hire them, have them go in, and help them go into compliance.
And those might be income, those might be ethnic, those might be...
That's right, that's right.
Any kind
These
of
are people who, for the most part, when someone they don't trust walks in and says, you have to do a little better on compliance, they'll go, yes, we will, and then they'll forget about it. But if you have somebody who lives in that area who's a community health worker who says, have you really done that? Why not? I know your mother, and so forth and so on. It's apparently that kind of thing that's being tried, and it's worked. And it is working for a fact in Brooklyn, New York, where they have a major operation doing it. It seems to be spreading out from there. I'd like to see more of that.
And do you think this is kind of the wave of the future?
And yes, and what we've really tried to do is again, one of the things when we were early on in the exploration phase of looking at the viability of a school, we asked stakeholders, what do you need in a pharmacy graduate in 4 years from us? And one of the keys that almost to a one, every person answered was a communicator. And not just a communicator on one level. Many people don't realize sort of the nature of the pharmacist as this liaison where they have to be able to articulate and in some cases argue a case with a physician on a level that sort of intellectually can go back and forth, but then in some cases bring things down to a 4th or 5th grade reading level for somebody who may warrant that, or again in a bilingual case potentially have that as a skill set as well. So we really tried to roll in a lot of communication skills into our program. And not just, again, not just talking through things or not just going through things. The pharmacist really is one of the few healthcare professionals who's always accessible in that while it may be a commuting issue to get to a hospital or to get to a clinic, most towns have a community pharmacy, whether it's a chain or whether it's an independently owned pharmacy.
And that's
there's someone there.
That's where you envision most of your graduates working in a...
We envision that just based upon statistics that a good number of them will end up gravitating towards community pharmacy. Many of them come in already with an experience having worked as a technician, and I think that's sort of their love and their passion. We hope to expand the horizons of where pharmacists are going so that they are in public health roles, so that they are in hospital settings, so that they are working in clinics or in accountable care organizations. They're working to design or to write the medical literature for major pharma corporations to get it to a level where it's understandable and that you can distribute information and put together health and wellness programs that sort of target certain communities. So we really see that ultimately, with the changing face, I think, of education in general, where we've become much less of a society that has to know everything in our head because it's so at our fingertips. Our students, we're not going to educate them to memorize the top 200 drugs because the reason is simply,
they don't have to know that.
We gave everybody an iPad when we came in as part of our program. They have that on their device at a moment's notice. In a year when the top 200 list changes, they can look it up. But there are certain things that a pharmacist has to have. Communication is one. An understanding of the sort of patient condition is another. An understanding really of the fact that their role is a health liaison, that they are a public health advocate, but at the same time they are a medication advocate, and at the same time they are the person who's an educator, but also a counselor, and also sort of in many respects, a customer service agent as well. So it's, I think, a skill set that we really tried to build where it's not just somebody who knows all the drugs. That's not enough.
That's a lot of responsibility to put on a pharmacist or to put on someone who works in an FQHC, and as you mentioned, it's really incumbent upon the provider. So with less resources, fewer resources than you had before, are we optimistic about the way things are going in just really empowering physicians and pharmacists?
In the face of the recession, I'm optimistic only with the implementation of the Affordable Care Act. Everything else seems to be pulling resources away from us. For example, we had a program about 2 years ago where public health nurses who audit daycare centers for immunization compliance of certain sorts, we said, okay, let's go out and do that audit and let's find out what the state of the art is. We found that the daycare centers welcomed those public health nurses, needed the information, but they did not have the medical or health capabilities to enforce the state's requirements. We set up a program. Not only did we get it enforced, we educated the parents, educated the daycare center managers, and we had a tremendous amount of success publishing a manual which we put online that anybody who wanted it could use it in any daycare center in order to understand what's going on. Our objective was to take, we did this in 5 towns. Our objective was to take it countywide. We can't. We haven't got the resources.
And this is affluent Morris County.
This is affluent Morris County. It's hurting.
Is that, do you think things will change as the economy improves? Do you think it's a commitment, or do you think it's just a financial?
It's not a question of commitment. as much as it is the idea that the tax revenues are down in the municipalities because of the decline in tax collections and housing values. And until that changes, there's going to be a decline in the number of people who are available in public health to do this kind of work.
And even, I mean, this is something you cope with all the time. I mean, you never have an abundance of funds. So.
We don't have an abundance of funds. I continue to be optimistic. I certainly believe that an emphasis on primary and preventive care is a bipartisan issue. We had Governor Christie at our health center last week, and he declared he was doubling down on the health centers. It was quite an event. And
you got that on tape.
We did. We got that on tape. And he has committed certainly to increasing the pool of funding for the health centers here in New Jersey. I think he and really folks across this political spectrum understand this issue around primary and preventive care and the sense that it makes in terms of saving on the acute care side and the emergency room side.
And yet in New Jersey, we still don't have a health insurance exchange.
Correct.
Which by law has to be put in place by 2014. Depending on how it gets accomplished, but hopefully we'll have one soon in New Jersey. Do you think that will have an impact? If theoretically now we all have access to insurance?
I do. I think also the expansion of Medicaid is a real open issue in New Jersey. The governor's been on the fence, hasn't indicated, and I'm sure he won't indicate until after the election just what he intends to do about an expansion of Medicaid. Certainly we believe very strongly that an expansion of Medicaid would help the patients that we serve. And I do believe that there are many thousands of people in Morris County who would buy insurance if it were affordable, absolutely, and are very uncomfortable with remaining uninsured. We also see a lot of young people, those folks who now suddenly have access to be on their parents' insurance up to I believe it's 26. Maybe in New Jersey it's even 31.
I don't know.
There's actually a broader designation in New Jersey, but sometimes the additional cost to the family of putting that child on the insurance is unaffordable. So I am optimistic that there will continue to be an increase in emphasis on primary and preventive care. I believe, however, that lifestyle issues are significant across the economic spectrum. We have a childhood obesity initiative. Frankly, that affects everyone in Morris County. It's a growing problem.
Bob, what are some of the specific health issues that you see that might be more prevalent? You mentioned breast cancer is prevalent in Morris County.
I'd like to see strengthening of local public health so they can continue their work in inspections and education.
But in terms of specific health issues, do you see therapeutic areas, disease states that are of particular concern to public health officials in Morris County?
I look to generally the problems of the elderly. Morris County has the fastest growing elderly population in the state. And of course, people over 50 years of age are the ones who tend to climb the curve when it comes to needing health services.
Chronic
I'd like
disease.
to see that strengthened across the board. Secondly, I look closely at the middle income people. There was a wonderful study put together by the Morris County United Way called the ALICE study. It's an acronym for something, and I can't tell you what it is.
Asset limited, income curtailed. What's the last one? We've actually worked with them on the report. Yeah.
Okay. Well, they have identified that certain middle-income populations are struggling, and if they're struggling, they are likely not to have health insurance easily come by or to pay for out-of-pocket health care. So we'd like to see some attention paid to that. There are a number of people in some of the wealthier towns in Morris County who are turning to some of the local clinics, such as exist in Madison, and some of their health officers for certain services that they never would have gone to, say, 5 years ago.
And Mike, your first class will actually graduate when?
2016.
So well after the implementation,
yes,
possibly, of ACA, depending on what happens with the election this year. How are you preparing them for the shift?
One of the things that we've done is into our first year curriculum, we have a couple of what we call our professional pharmacy practice courses, which are really the core practice of pharmacy issues. So there's a course that right now is being conducted where we're talking about the aspects of billing and reimbursement and Medicare and Medicaid and all of the core issues of really what a pharmacist deals with on a day-to-day basis that go beyond simply dispensing medications. You know, the obvious output that you see is all of those bags in the back of the CVS or the Walgreens, but there's so much that goes into that a pharmacist needs to understand. And we want to make sure that pharmacists are really speaking the language, because we believe that the pharmacists graduates that we educate now and put out as our product in 2016 have to not just be advocates for the profession of pharmacy, but have to be real advocates for health and wellness. And we want to make sure that they understand, not just in a sort of a myopic view from the pharmacist, but of the entire healthcare team and of the entire healthcare perspective. What does it entail when a patient comes in with a certain condition? And where did they come from in terms of what happened before, and where are they sort of going to? And I think a lot of what we're seeing as well is a lot of focus that we're doing on some of the chronic disease states that some of which have been sort of identified and articulated, but pharmacists have now started to take a leading role in diabetes management, which is again sort of related to the obesity epidemic. And so we've started to really provide our students with some focused skills there on oftentimes things like cardiac and cholesterol and other types of therapeutic management there. As well as obviously now an increase in sort of the infectious disease control with vaccination and immunization programs that many pharmacies are running and many pharmacy programs are sponsoring.
How's the supply of pharmacy students? Will you have enough pharmacists to meet the demand in New Jersey?
Right now, because of the economic downturn, there has been sort of a pullback on oftentimes pharmacists who are at retirement age from actually pulling out and retiring. So the job market right now is not as robust as it was. However, our projection is that we believe the trend suggests that with an aging population needing more therapeutic management, and with the potential for how sort of this new healthcare dynamic plays out, that pharmacists will be needed in a lot of areas that they've yet to be called upon. We're actually excited that putting out more graduates, we believe, strengthens the profession. It may initially seem as though, well, there's not enough jobs, but we believe that there are jobs that pharmacists can and should be doing that they've never done before there because there haven't been enough to go around.
And what do you see, Eva, as some of the changes that are going to be coming to FQHCs, to yours in particular, in the next few years?
Well, the Affordable Care Act contained $11 billion for the federally qualified health centers around the country. Some of that money's already started to flow because the act is law. And so we actually have been the recipient of some grant funding to expand into some new areas. We have a new site in Hackettstown, which is funded by Affordable Care Act. And I believe there will be further expansion of health centers. There is a big push to make all of the health centers patient-centered medical homes, so we are under the gun to do that. And we are also being scrutinized, and I think this is going to be across the board for not just health centers but for physicians in general. We're being scrutinized for quality and outcomes, and there's a lot of talk about pay for performance, so that we're not just going to be paid for how many visits we have and a straight amount per visit, but rather, you know, what are the outcomes that we're achieving? Are we getting people under control in their diabetes? Are we controlling hypertension? Are we doing smoking cessation with every patient who indicates that they're using tobacco? So we are being...
We talked about education.
Absolutely,
the
education.
Now being held to performance,
and
but
yes.
Now physicians are going to be held to the same performance standards.
Absolutely.
As teachers are being
Absolutely, and that I think is really a long-term trend that is going to happen one way or the other. That's why the Affordable Care Act is important, and the accountable care organizations that stem from that act are a first step. Here in Morris County, there is a large one already that is within the Atlantic healthcare system. We're a member of that. We're going to be able to show that the care we provide actually makes people healthy and keeps them healthy.
Mm-hmm. And Bob, I think we're going to take the last word here with you, but let me ask you just to, you talked about the changes that have been forced upon you in effect by the recession, the lack of funding. Given that this is something that's probably not going to be changing in, in the next 15 minutes, how are you coping with that, and how do you anticipate dealing with that in the next few years?
Well, on the municipal public health level, there has already been a long history of shared services and people cooperating with one another. They're way ahead of the game compared to other municipal departments of government. I expect we're going to see more of that. I think there's money coming down from the feds for education and health manpower education. And I'm hoping some of that translates to what we need here in Morris County.
And I think further collaboration. I mean, we have a strong relationship with our local health departments. We actually partner with Rutgers, and hopefully with you guys at some point, to have pharmacy students in our health center. So I think that with limited resources, we are doing much more collaboration.
Okay, and just to sum up in last words, are we positive, optimistic, or not about the future of healthcare and really what it says about individual health, the quality of health?
I believe that I see a very positive or a potentially positive future for healthcare as we begin to focus more on really intervening before things get to a critical state. I think that's been a shortcoming, as I think has been cited here multiple times, on the American healthcare system, is that it's reactive rather than proactive.
Mm-hmm.
And as a result, I think oftentimes you see people wanting to sort of practice in a sense, sort of the healthy lifestyle, but having a team that's encouraging that, and having a team that's staying on top of that, and having a team that's sort of assembled to try and target what that means and define it, and then sort of put out resources to fulfill that, I think is going to be sort of a dynamic shift for the healthcare system.
A shift to wellness as opposed to...
I think it's a critical shift, and I believe that's sort of a lot of what is being supported now as sort of the network gets larger between doctors and nurses and pharmacists and other officials within the healthcare team. I think that to me seems like a very good step in the right direction.
Eva, from your perspective?
Well, I'm also optimistic, and I do believe that if we can figure out how to increase access, either through insurance or through health centers such as mine, if we can focus on, once again, a team approach, and if we can focus also on the social determinants, I'm optimistic
and
we
you think
can.
that things are in place in New Jersey to help that happen?
I believe New Jersey is a leader in the country. I really do.
Great. And Bob? Last word.
Guardedly optimistic, but only because of the Affordable Care Act, at least as it affects local municipal health departments and the people they work with. I come through a professional door, not a political door, but we have slim resources, and if that Affordable Care Act stays in place, I think we'll do okay.
Because it's all about being able to educate people, and again,
It
you
is
would follow
devoted
this
to
trend
the
to
maintenance
wellness.
of health for Morris County residents. Clearly, the same mission that Eva's organization has. We do it a little differently, but without the resources, we can't do a thing.
But we think the resources are on the way.
We do.
We do.
Terrific. And on that optimistic note, we'll end this discussion. Thank you all for participating in State of Health Morris County 2012.
Thank you. Oh, yeah.